This is Megaphone from Medvale Media. I'm Dave Sell. This is where we hand the megaphone to healthcare leaders to share their thoughts, perspectives, and the occasional rant about the always dynamic world of healthcare. Today, we welcome Bruce Cummings, who, along with Dr. Paul Deschamps, co-founded Organizational Wellbeing Solutions. Bruce has a 40-year career in the hospital and healthcare industry, and now focuses on reducing the incidence and severity of burnout in healthcare. Hello, Bruce. Thank you for joining us.
Thanks, Dave. Great to be here.
Bruce, let's hand you the megaphone and start with an observation, please. Reflecting on your many years in healthcare, did you see this age of burnout coming at us?
In all candor, no. And in fact, I retired some 7 years ago from the CEO ranks, and I took a couple years off. Probably had a little bit of burnout myself. And I was 65 at the time, and I figured, well, this is great. I'll just enjoy retirement and take up a number of hobbies and so forth. But after about 2 years, although I continued to follow the field, and during that 2-year interregnum, I reflected back on my career, things that had gone well, things that I wish I'd done differently. And I realized in that 2-year period that I had missed what was then kind of the beginnings of the burnout epidemic. It was there, it was below the surface. It hadn't really found full expression. That certainly was catalyzed by COVID. So after about a 2-year hiatus, Paul Deschamps and I found one another, as it were. He was already active in the field. And one of the things that I had come to appreciate is that I and most healthcare executives had missed the underpinnings of the burnout epidemic, but more importantly, most executives then and now had missed what actually causes burnout. I think the popular wisdom, and it's still unfortunately the prevailing notion, is that, well, people are tired, but everybody's tired. Burnout is just part of life today and not much you can do about it. And if we're going to do anything about it at all, let's appoint a chief wellness officer. Let's expand our fringe benefits and do things like offering yoga or workplace, guided imagery, meditation services, maybe a literature and medicine course. For our beleaguered doctors, maybe a concierge service. And, none of these things are bad. In fact, all of them confer some kind of value, but they have absolutely nothing to do with the causes of burnout. Burnout is an occupational disease. It's an occupational result from conditions in the workplace. It's a personal response to chronic toxic issues in the workplace. So it was that epiphany that what burnout is and what it isn't, and the role of senior leaders that heretofore had been kind of missed. I think most leaders had missed what their role and responsibilities are relative to this. It's they who ultimately can most impact the workplace. That's really what brought Paul and I together to say, how can we help senior leaders better appreciate what burnout is, what it isn't, what are the drivers, and what are the countermeasures that leaders can implement to reduce the incidence and severity of burnout.
Well, maybe not an epiphany, but it sounds like certainly there was a realization on your part of some of the dynamics involved in that. Is that what inspired you to start Organizational Wellbeing Solutions with Dr. Deschamps?
Yes, I mean, we had worked together for other organizations on this issue of burnout, and ironically, we had come together to co-start a consulting service that was going to be a subsidiary of a major healthcare consulting firm, and we had just gotten the dimensions of this startup put together. And it was going to be very focus, as most traditional consulting services are, on face-to-face meetings, going to the workplace, talking with frontline staff, talking with the C-suite and so forth. And then COVID hit and everything came apart. No airplanes, no meetings, line items for consulting services were essentially zeroed out, all entirely understandable because it was all hands on deck in terms of trying to survive the immediate challenges of burnout. So we were primed and ready to go, and then COVID, life interrupted, and we didn't really get to launch it then. But 2 years ago, Paul and I formed organizational well-being services to pick up where we had left off, or where the epidemic had left us off, to begin anew this work.
Well, the COVID-19 pandemic certainly amplified, maybe even accelerated the feeling of being overwhelmed or burned out among care providers. But was there already a problem brewing before the pandemic struck? It sounds like you may have identified that if you and Dr. Deschamps were already engaged in this. So, what were some of the early red flags that you saw in the industry that caused you to say, there's a problem and we can help solve that?
Right. Well, maybe this would be an appropriate time just to introduce the name Dr. Christina Maslock, who is the foremost researcher and writer on the subject of burnout in the workplace. And she and Michael Leiter, her colleague, have been at this for literally a couple of decades. And one of the things that she points out is that there are actually three manifestations of burnout. One is probably known to everybody, and that's what most people typically conflate with burnout, and that is physical exhaustion. I'm just tired, I just can't do this anymore, and so forth. That is one, but that's only one of the three manifestations. The other two are often underappreciated and underrecognized, and these are particularly common now among clinicians, and interestingly now, even among healthcare executives. Some 60 to 70% of both clinicians and healthcare executives are reporting burnout. And those other two manifestations are cynicism and a sense of inefficacy. I have all this training, I have this knowledge, I know what needs to be done, I just can't get it done. I feel inept, inconsequential. And the cynicism is, why try anymore? It just doesn't seem to make a difference, and so forth. So it's really those three manifestations that truly constitute burnout. So healthcare leaders typically understand that there is a physical and emotional dimension to burnout, but fail to appreciate that cynicism and inefficacy are the other two manifestations of burnout. And one can easily see why that would be a problem, why COVID-19 did not create, it simply amplified or accelerated these three manifestations, because particularly physicians then and now are feeling overwhelmed by the electronic health record. Instead of making the ability to provide better care, many of them feel they've been reduced to being data entry clerks. Not the highest and best use of their time, and that you can see how that would contribute to the sense of inefficacy. I'm just not making a difference to my patient because I'm spending all this time in the EHR, or there are supply chain shortages, or I can't get the kind of staff, and I don't have enough staff or the right kind of staff to be able to get my work done. All of those things contribute to a sense of inefficacy. And if those issues are repeatedly raised to senior management and there's no recognition of the problem or no change in the circumstances, then that contributes to this sense of cynicism. So that's what Paul and I try to focus on. It's not just one manifestation, it's all three. And senior leaders must play a very direct role in tackling all three of those manifestations.
Those really sound like the root causes. Is that a fair assessment? You've got these three manifestations, but below that, you touched on some of the things that would have caused that feeling of I'm not moving the needle in a positive direction for my patients. And the people actually providing care feeling less than operating at the top of their license. As you said, a data entry clerk. That I've not heard it categorized quite that way, but that's a pretty damning description of what I think a lot of our colleagues that do provide care have felt, not just because of EHRs, but certainly that has not helped the situation. So would you say that the root causes are stuck um, in those manifestations that you touched on?
Well, there are multiple drivers. Those are the three manifestations, but there are a number of factors that give rise to those manifestations. So work overload is certainly an obvious one. Um, but so too is a lack of recognition or reward, feeling I'm doing all this work and no one seems to appreciate how difficult it is, or I'm not being fairly compensated and so forth, is can be a driver, not in every instance, but in some instances. Values conflict between, let's say, my calling as a physician or my training as a nurse, what I know ought to be done for my patients, but I'm unable to do it, or the organization impedes my ability to do this, creates a values conflict, and that can be a driver. A loss of community. And I think, Dave, you and I have been around a long time. We remember the days when, physicians would be hanging out in the physician's lounge. There'd be a lot of corridor consults. There was a camaraderie, uh, uh, a propinquity, a nearness of kin that came from frequent interactions within the hospital. And that just doesn't happen anymore, right? There are hospitalists who provide the inpatient services. Primary care doctors, by and large, are now entirely outpatient. They don't come into the hospital. And so there's that lack of community that used to characterize the profession. There are factors that where people do not have the control over certain factors in their lives, like gender or sexual orientation, and may feel that that loss of inclusion, because they may experience discrimination of one type or another, either from patients or potentially from colleagues. That too can be a driver. So it's typically not a thing. It's a combination of things. And one of the things that Paul and I try to do is actually drill down and learn what are those key drivers, because chances are it's going to be different from place to place. For example, an organization that has invested heavily in remediation or optimization of its electronic health record probably will not have as high an issue with work overload or a sense of inefficacy as a place that hasn't done anything about it. So the EHR may still be an issue in both organizations, but it may not be as much a factor in one as it is in the other. So we really try to get a handle on what is the signature, what are those specific set of drivers, and to what extent is it pervading the organization? Is it department specific? Is it entire division? Is it the whole of organization?
What you described really sounds like loss of agency for the people providing care. There have been so many changes that have come so fast that it's been taken from them instead of given to them. And that, at least that's how it lands with me. Is that a fair assessment?
Yeah, that's a fair assessment. Paul has a great phrase he likes to use. He didn't coin it, but he uses it liberally, and I always associate with him, and it's called administrivia. Just meaning the sum and substance of all the stuff that happens that takes doctors and nurses away from taking care of patients. And we estimate that about up to 2/3 of a physician's time today is actually spent with administrivia in non-value related work. Only about a third of their time actually directly providing patient care. Think about that. Two-thirds non-value added, one-third responding to things like prior authorizations, or we're dealing with compliance reports, or having to call an insurer to contest a certain finding about coverage and so forth. And so we like to ask, well, what if we could flip that ratio? What if we could working with senior leaders, make changes in the work environment so that 2/3 of that clinician's time could be spent in direct patient care, and only 1/3 doing things that we recognize that still a number of them are necessary, but maybe not to the same extent that happens now in a work environment that hasn't really been closely examined. We think that would confer tremendous value not only to the clinicians, but to the patients and to the organizations by having a much more engaged and healthier workforce. So that's one of the reasons why we came up with the name, and it doesn't exactly trip off the lips of organizational well-being solutions. We're not focusing on trying to provide more yoga in the workplace. We're trying to change the workplace to make it healthier and more resilient, in which people can realize the full expression of their talents.
It also sounds as though without executive leadership, not just participation, but strong support, that the effort that you and Dr. Deschamps would bring to an organization would be suboptimal at best.
Yeah, that's true. I mean, I think there's, imagine just a direct linear relationship. The greater the involvement of the senior leadership team, the stronger and better the results. Conversely, if this is an effort that's delegated to a vice president, or a director of organizational development or something, there can be some benefits, there can be improvements, but it won't be nearly as pronounced, and it won't be as durable as if it becomes a whole of organization effort. And to create a whole of organization effort that's really durable requires the senior leadership team to really embrace something like this.
Society is so fond of creating a catchphrase and then using it until everyone is tired of it, and it's on the next train to cliche town. Has burnout become that cliche for a whole bunch of situations that people find themselves in the healthcare experience? And along that line, among the organizations you work with, are there a common theme or two that you find being the drivers?
So, to your first part of your question, I would say yes. Unfortunately, um, I think the prevailing wisdom is there's burnout everywhere. I'm feeling burnout. It's endemic in life. And so what are you going to do? I think there's that sense of resignation. And again, that comes from, I think, not appreciating the three manifestations and the six drivers, and the fact that there can be changes that will be highly impactful by tackling the workplace, as opposed to trying to, uh, tackle the individual, as it were. So that is definitely a challenge, that cynicism or cliche, or it's ubiquitous, and what are you going to do? That is definitely a challenge to try to get to increase the level of awareness that this is not preordained. Um, and so that's part of what we see as our mission. We do a lot of work that's not compensated, just writing blogs and articles and appearing at conferences and so forth, to try to increase the general awareness in the health field in particular, that this is something different from just feeling tired, or it's not the kind of thing where you just have to throw up your hands and say, well, there's nothing that can be done about it. It's just part of life. It doesn't have to be part of life.
Any theme that you would be, or themes that you could call out that you typically find in organizations as you begin your work with the leadership and with the care providers themselves? Any themes that you could call out that might be um, markers that those seeing this podcast might recognize in their own organization?
Well, the good news, I think, there's now widespread recognition about the primacy of the electronic health record being a common denominator, um, although perhaps erroneously thought to be the only driver of burnout. So that's the good news. At least it's a starting point, um, or this notion of it, the administrative burden falling on clinicians. So that's almost a universal problem, but the good news, it seems to be almost a universal recognition. But here's the challenge. We're seeing that around the country, I read a report that up to 80% of hospitals and health systems plan to invest in AI over the next year. And absolutely, AI can be a very helpful tool, particularly with respect to some of these administrative burdens, to optimize the electronic health record, some of the new large language models, AI enabled, that will eliminate the data entry, so forth, and even create suggested codes and generate patient instructions and so forth. This tremendous potential here. And some of the other AI applications we're seeing that can be very helpful are things like supply chain management and scheduling tools and so forth. Since greater work flexibility around scheduling, there's one of the things that nurses and doctors across the country are looking for. So there's a lot of promise here. The problem is that what we're seeing is too many places are saying, AI will solve all of our problems, as opposed to it can be a useful tool. And just recently, I read an interview with the MIT professor who just won the Nobel Prize for Economics, and he estimated that AI will only improve about 5% of efficiency in the workplace. He wasn't talking specifically about hospitals, and he admitted that was not a scientific figure, but his point was there's too much hyperbole around what AI will be able to do, which brings me back to rather than think of AI as the panacea, it's important for leadership teams to look at what are those policies and practices and procedures that may militate against physicians and nurses working at the top of their license or having that sense of efficacy. The AMA has a great phrase, gross, getting rid of stupid stuff, which is a great phrase. Paul and I are big proponents of process innovation, and more specifically, the use of lean problem-solving tools, but similarly, operations research, Six Sigma design, or agile thinking can all be brought to bear to streamline operations and get rid of unnecessary steps. So AI won't be able to solve all of these, but by having a comprehensive approach that identifies what are the pain points that people on the front lines are experiencing, improving the communication and decision-making cycle time between the front line and the executive suite, things like that AI will not be able to touch, actually can be at least as powerful, if not more powerful. So that's where we like to focus, or what are sort of the human factors changes that can result in profound improvement.
Well, you're touching on something that we've hit on before here on Megaphone, and that is artificial intelligence has become that great bushel basket into which people just chuck things that may or may not be related. It sounds cool to talk about AI, and my organization is investing in AI, and we have an AI leader, and we have an AI workshop. The fact is that it's not a panacea. And where we're beginning to see, and through observation, is the best and highest use of artificial intelligence tools, as you point out, in healthcare is augmentation, not replacement. because it still is a person to person equation. And to the degree that we can remove the barriers and friction between those that provide care and those that receive care, that's a win. But simply looking to technology to take the place of something that is a very personal, relationship based um, situation just doesn't seem to be in anyone's best interest. So thank you. Thanks for calling that out. Normally, Bruce, we ask guests to gaze into their crystal ball and give a view of the future, but I need to try something different with you. When you look into
Well,
your crystal ball, what what should the healthcare industry be adopting to address professional fatigue and burnout? And you've touched on some high level themes, but let's bring it down from 40,000 feet to 6'2" or whatever your native height is.
I'll pick one category, or I'll offer a few examples of how relatively, I don't want to call them easy changes, but it's just kind of a change in mindset can make a big difference. So there's probably not a hospital leader in the country who doesn't appreciate the importance of communication. And most hospitals have a communication plan of one type or another, and recognize its importance. But often senior leaders don't appreciate that. Let's say they're putting out a lot of emails. And by the way, this is part of my own revelation, because I would send out emails to my staff all the time about the latest developments of this, that, and the other, only to discover fairly late in my career that a lot of people just weren't reading them, didn't have time. They were too busy to read them. Or So I'll give an example of two things that where a change can make a huge difference. I'm going to put them under the broad banner of communication or decision making. One is that most senior teams around the country support and even may engage with rounding. Sounds like a good idea. I was a big proponent of it. I would do it with my whole senior management team. We would go around, visit units and so forth, and ask a series of questions, and always beginning with safety and the like. What I did not appreciate until after I retired and looked further into the evidence around this is it's totally ineffectual. Rounding is largely ineffectual
Really?
when done by senior leaders. And as some clinicians have told me over the years, if I or another CEO show up and say, how's it going? What do you face challenges today? And I've had a number of folks say, well, I have two choices. I can either say, fine, all's well here, and I'll only be 5 minutes further behind, or I can actually tell you the truth, and then I'll be an additional hour behind. So I'm gonna tell you little or nothing. Everything's fine. And moreover, showing up in a suit, and especially if joined by their senior executives, does not put people at ease. I learned it's actually off-putting. So what to do? What's better? What's better is job shadowing, where arrangements are made in advance with a willing nurse or pharmacist or a therapist or physician, put on scrubs and actually follow that person around while he or she goes about their daily routine. And the key thing is to observe and listen. Don't offer suggestions, just take it all in. And that act has two benefits. One is the executive will acquire a much better appreciation for what the staff are actually experiencing on the front lines. But that's also, it's sort of like the undercover boss. It just creates that word of that will get around that, oh, you know what? They actually really are interested in what we're doing. It's a very powerful strategy to help narrow the schism that exists today between the C-suite and the front lines. So here's another. Um, there are so many complaints in almost every organization about decision making. It takes so long to get an answer about something. There's always this long lag, or what the C-suite is talking about, that's not of interest to me. I'm just, as one nurse told me, my mission is not what's hanging up on the wall, your mission and vision statements. I can't even remember what they are. They all sound the same from place to place. My mission is to try to get through the day. So how can we reduce the friction that doctors and nurses feel on an everyday? By creating what's called a daily management system, a communication system that's highly choreographed, that begins with highly choreographed huddles on the front lines, take no more than 15 minutes, supported by a visual aid, a whiteboard or electronic board. You have to coach, you have to train people on how to run an excellent huddle. It's not what people think it is. In most hospitals, again, like rounding, they all say they do huddles, and most of them are not very effective. But with a daily management system, it is possible to link those issues that arise at the front lines up to the next level, the third level, maybe even right to the C-suite, so that it increases the cycle time, or I should say decreases the cycle time, so that just issues that are problematic, little issues that just drive people nuts because they happen over and over and over again, get resolved now on a timely basis. So those are just two of some of the strategies, the tactics we often recommend that make a meaningful difference in both communication, but it also has this tremendous benefit of narrowing that gap, that schism between the C-suite and the front lines.
You get the last word, Bruce. What message will you leave us with today?
Well, for all of its turbulence, the ups and downs, the financial pressures, the inanity of what I like to call, or actually it was Rosemary Stevens who coined this phrase years ago, the American non-system of healthcare. It is still a fantastic place to make a difference for clinicians, for administrators, for support personnel. And so for all the comments that I've made, none of this should be construed to discourage people from entering the field or staying in the field. But what I hope I've been able to do is illuminate that there are solutions to a lot of the issues that vex staff, including executives, that can make it a much better work environment. So in the end, I'm actually optimistic about the future. AI will be a help, but just as you point out, Dave, don't rely inordinately on it. It's just a tool.
Bruce, thank you very much. Our guest today has been Bruce Cummings, co-founder of Organizational Wellbeing Solutions. Thank you so much for sharing your time and your wisdom with us. And join us next time for another edition of Megaphone from Medvale Media. I'm Dave Self. Be well.